We're going live, yeah. Alice, if you can share the link to the live so that I can share it in the group chat.
Yeah, hold on. It's still
Thank you.
loading.
Non ha mai fatto queste cose.
Hello everyone and welcome back to the Orthodontics webinar series. My name is Omar and I am the webinar director at the SCORE committee. It's a pleasure to have you all with us today for the second session of this series. Before we begin, I would like to briefly introduce the International Association of Dental Students, IADS, a global organization that connects dental students from around the world and promotes academic exchange, professional development, and international collaboration. The webinar series is organized under the SCORE Office of IADS, the Standing Committee on Research and Education, which focuses on advancing research, education, and global engagement. Through SCORE initiatives, students have the opportunity to learn from experts, participate in international activities, and broaden their academic experience. We are delegated to continue this orthodontic series, a specialty that contributes significantly to improving oral function, facial harmony, and long-term oral health. We hope today's session will be insightful and beneficial for everyone, and it's a great pleasure to welcome Prof. Daniele today, and we sincerely thank him for joining us and for sharing his expertise. To introduce our speaker and guide us through the session, I would now like to hand over to my colleague Emiliana.
Hi everyone, it's my great pleasure to warmly welcome you today to today's webinar entitled Temporomandibular Disorders in Daily Clinical Practice. We are delighted to have with us today Professor Daniele Manfredini. Professor Manfredini has consistently been recognized among the top experts worldwide in both temporomandibular disorders and bruxism, making it a true privilege to have him with us today. Thank you, Professor, to accept our invitation. Professor Manfredini is professor at the School of Dentistry of the University of Siena in Italy, where he teaches oral physiology and clinical gnatology and serves as director of the orofacial pain unit. Throughout his distinguished academic career, he has authored more than 350 scientific publications and has consistently been recognized among the world's leading experts in temporomandibular disorders and bruxism. He currently serves as editor-in-chief of Cranio, the Journal of Craniomandibular Practice, and holds leadership roles in several international scientific organizations, including the International Association of Dental Research and the International Association of Orofacial Pain. In today's webinar, Professor Manfredini will discuss the current understanding of temporomandibular disorders, focusing on the overload model, the interaction between biological, physiological, and social factors, and the evidence-based principle that should guide diagnosis and management in daily clinical practice. We are truly honored to have him with us today and grateful for his willingness to contribute to our webinar series. And so, Professor Manfredini, thank you for joining us, and the floor is yours now.
Thank you very much, Emiliana. I will try to share my screen now. Here we go, right?
Yeah.
Okay, so actually, this is one of the situations in which it's pretty easy to say that the pleasure is mine, okay, and the privilege is mine, because one of the things that I love most in my profession and my discipline is talking to an audience of youngsters, not necessarily undergraduate students, but I love my postgraduates, the programs that may really be helpful to shape the future of our profession. Why? Well, because I think that even if you are dental students, you have probably perceived non-necessary complexity surrounding the field of temporomandibular disorders that in some countries is still referred to as the practice of gnatology, a term that doesn't make any sense and that brings on the table a series of complications that for those of my generations are simply associated with unnecessary business and money reward for the professionals using it. So my strong encouragement as the leader of this discipline around the world is that you start your professional growth with solid basis and by following the principles of evidence-based dentistry, which in the field of temporomandibular disorders simply means following the principles of orthopedic medicine. And that's what my lecture today will be based on. Well, first of all, a few words about my university. For the internationals, sometimes reading that we were founded in 1240 is unbelievable. It seems an error. No, it is not an error. I always used to say that, especially to my friends Americans. The circle there is the rectorate aula, and Siena, the arrow is in the 7th floor of the hospital up in the hill, my office. And actually we are the 5th eldest university in the world. But tradition doesn't come alone, as in the case of the crazy horse race in the main square of the city. Tradition also comes with quality in our case, because the University of Siena is one of the few school of dentistry that is part of the so-called President's Circle level. So basically, the analog of the IADR. So basically, the analog association of the IADS, the IADR, the International Association for Dental Research for postgraduates, recognizes the role of the University of Siena as one of the few leading dental schools in Europe. And especially as far as my discipline is concerned, we have the best program in the world. It is not, a self-proclaimed statement. It is just a matter of fact. Over the course of the past 5 editions, the master course in the postgraduate master course in orofacial pain and temporomandibular disorders can be followed entirely online. And over the course of the past few editions, we collected participants from 58 countries. So you can see the flags. It's unbelievable. And that is what makes our program unique for this kind of discipline. Concerning myself, I don't like to talk about myself too much. The curriculum is there to read. I was pretty young in the moment I was started. I started to be ranked #1 in my discipline, and it was something that basically came out of the blue because, of course, I love research. I publish papers thanks to my team, but the bottom line is that I'm a clinician. So I see patients on an everyday basis, and what I've learned in my career is that you have to protect patients from overtreatment. So studying over a mistreatment. So studying the right things to do, especially in this field, is very important since the beginning of your profession. As Emiliana said, I'm the editor of Cranio, the Journal of Craniomandibular and Sleep Practice, which is the official journal of all the orofacial pain academies around the world, and I'm also the vice president of the International Association for Orofacial Pain that I invite everybody to follow, because we have many programs and webinars that are free for everybody to use. Concerning myself, I was ranked 8th in the full world of dentistry as far as the scientific publications are concerned in the last rankings. But as I said, this is my real life. I see patients on an everyday basis. So what I will try to convey to you today is a clinically oriented message. I mean, there is an individual coming to your observation with the click in the temporomandibular joint, pain in the temporomandibular joint. What does it mean? What should I do? How can I treat these kind of situations? Okay, so of course, 1 hour is not enough to have a full overview of everything. But I hope I will be able to give you at least some inputs to generate enough curiosity to take part in our programs in the future, or at least to understand where to go if you want to choose this kind of discipline. Why? Because, unfortunately, as we showed in this paper coordinated by my daughter Aurora, the patients with temporomandibular disorders are still badly treated. The literature said to us decades ago that basically an hypothetical patient with pain in the TMJ or click in the TMJ has nothing to do with orthodontics, the analysis of malocclusion, the use of instruments to record electronically any parameters is not recommended. But in spite of that, what Aurora showed us is that even 26%, so basically 1 patient out of 4 is still nowadays recommended to do orthodontics for pain in the temporomandibular joint, and 2 patients out of 3 are in pain for more or up to 1 year, and some of them didn't receive any solution after 1 year. So it's pretty intuitive that this is not routine dentistry. You will see after the graduation that in the everyday dental practice, basically almost all the procedures tend to approach the 100% of success. Okay, so you perform an implant, you restore a tooth, you perform root canal treatment, even you manage perio, you align the teeth with orthodontics. The success is basically what the patients and what we expect from all the treatments. In the field of temporomandibular disorders, the criticalities are that we deal with patients with pain that is not necessarily acute pain, so the psychosocial component is much powerful than in the case of dental pain, but also the criticality related with the very bad education of generations of colleagues who still mistreated our patients. And why I'm saying that? Because the early stage of my career was based on this kind of practice that for many of you, unless you are sons or daughters of dentists, do not mean anything, okay? This was the analogic version of the fantastic digital instruments that we have now. I mean, the 3D and even the 4D simulators of jaw motions, the electronic recordings of electromyographic activities. Everything was functional. The face bows, analogic, the condylographic traces. Now we got the digital versions of that as well. Everything was instrumental, according to the proponents, to find the perfect correspondence between the condylar position and the features of dental occlusion to correct pain in the temporomandibular joint. So basically to treat the so-called dysfunctional patients. Now we know that this is completely wrong, and that's probably the main reason why a lot of patients still migrate from one professional to another. So, of course, the literature showed that dental occlusions is not a factor in the etiology and consequently is not a target for management of temporomandibular disorders. But this doesn't mean that you can do whatever you want with occlusion when you manage patients prosthodontically or orthodontically. So there are some basic general rules to provide a stable occlusal finalization at the end of ortho or big prosto treatments. So this is just good sense approach, but it has nothing to do with bruxism and temporomandibular disorders. So as an orthodontist, the standard of care when you got an orthodontic case that you start for aesthetic reasons that are the main reason to start an orthodontic treatment, you should finish like that, okay? So nothing less than aspiring to the perfection, okay? You should strive to excellence. But again, you should not look at this kind of malocclusion if the patient comes to your observation for pain in the temporomandibular joint or headache. And this is something that I learned when I was a student, and time flies, as we used to say. I graduated 27 years ago, and I was the first dental student in Italy and one of the first in Europe to perform an undergraduate thesis in psychiatry. Okay, so the topic of my thesis, the Italians who are connected right now can translate the title, concerned the role of the psychosocial factors in the genesis of basically what we now call the temporomandibular disorders. And since I was a student, I recognized that these kind of individuals with pain in the face basically share a lot of similarities with the patients affected by other symptoms of psychosomatic origin. Irritable bowel syndrome, fibromyalgia, headaches. Okay, so the profile of and scores of anxiety scales, depression scales, somatization scales were pretty identical. And we published my thesis years later. My professor was not a researcher, so I did it almost everything all alone. And we also published the same, in the same time, the data on the analysis of dental occlusion on similar patients. Dental occlusion was not a factor to predict the presence of pain. Psychological factors were. So, for those of you who are familiar with topics and terms like centric relation, it is important to know that actually that's only about the hardware. So the position of the condyle, the position of the teeth. But what makes the difference is the software, so the central nervous system of the patient. For a very simple reason, pain is an experience. So it is a subjective and unpleasant experience by definition of the International Association for the Study of Pain. These were some pictures of my thesis. And I used to say in the years following my graduation, when my professor started to recommend my name to give oral presentations here and there, I started to joke and said, who's the most likely candidate to have TMJ pain in your offices? The shepherd or the lady manager? Okay. Well, I guess that we all know that the lady manager is the most likely TMD candidate. And when you are super happy during your honeymoon, it is very unlikely that you will have TMDs. But I don't think that during the honeymoon, your occlusion changes with respect to your everyday life. So it seems to be very stupid to reinforce this kind of message with these kind of examples. But the first requisite for an etiological theory to be potentially valid is the epidemiological verification. So let's get into the details. What are the signs and symptoms of temporomandibular disorders? Well, click, function limitation, and or pain. Okay, these are the three main reasons why the patients come or may come to our observation. So we will examine them in deeper details in a few minutes. But before that, there are some specifications to make. Well, first of all, temporomandibular disorders are the musculoskeletal pains of the face. So from semantic and from mechanism-based definition, they are in most cases nociceptive pains. So there is an inflammation within the synovium of the temporomandibular joint or within the tendons or in the capsule that is responsible for pain. And the resolution of that inflammation, sometimes even just with rest or painkillers, that's why an appliance, for instance, is useful in many cases, is sufficient to help patients solving the pain in most cases. And this is absolutely the opposite with respect to neuropathic pain and especially also nociplastic pain. So the situation that is the result of chronic pain that independently on the location for sure is associated with central sensitization. So the peripheral inputs, both as a diagnostic and therapeutic target, are less important. And this is extremely important for you to know because the mutilation of patients sometimes reaches crazy levels, okay? We see patients that in the name of dental occlusion may be subjective to this kind of super extensive treatment on the teeth and crowns for what in this case was a neuropathic pain. So this was a 25 years old lady who underwent 28 root canal treatments and crowns without any real reason. And she was put under treatment with neuroleptic drugs because the reason for pain was nociplastic pain. So this is an editorial published in Cranio that you can download for free if you frame the QR code with your phone on the professional burden of protecting these kind of patients who are in most cases simply frailty individuals. And from that need to protect patients, we developed a very nice idea when I was president of the International Association for Dental Research for the section of orofacial pain. We prepared a document entitled The Key Points for the Good Clinical Practice in the Field of Temporomandibular Disorders. Also, in this case, the QR code leads you to the full text, which is basically a decalogue of good and less good points to take into consideration when dealing with these kind of patients. I will read them and then we will move to the clinical part, the second part of my lecture. First of all, any decision should be patient-centered. Very basic information, but it is needed. I see a patient with a click in the temporomandibular joint. All my efforts should be directed to the evaluation and explanation concerning the click. I shouldn't evaluate cephalometric the patient to plan orthodontic treatment. TMDs are dysfunction of musculoskeletal origin already, we have already said it, and the etiology is biopsychosocial. This requires a bit of explanation because I don't like necessarily the abuse of the word biopsychosocial. What does biopsychosocial mean? Of course, a lot of factors, biological, psychological, and social, may interact to determine the onset of TMDs. But in the specific situation of temporomandibular disorders, what really makes a difference and is very useful to know in terms of pathophysiology of the symptoms is that most patients have an emotional overload that they translate into hypervigilant from a neurological perspective and muscle tension from a musculoskeletal perspective. So the result is that the system in some predisposed and frailty individual get injured. So you get inflammation as much as some of us get trained in the gym and others get injured. So the challenge is to understand why someone gets injured and some others get trained, okay? But there is no doubt that these factors, or better, these outcomes do not depend on factors like dental occlusion features because we don't live with the teeth into contact, okay? So again, from an epidemiological viewpoint, there is not enough solid ground to hypothesize a role for dental occlusion. The diagnosis, as for all the other joints, is based on a careful anamnesis, so the history taken, clinical assessment, and imaging. Which kind of imaging when needed? MRI. That's the standard of care. As dentists, you will see that also in this case, there is a misconception towards the abuse of computerized tomography. Now that we had the CBCT that is more favorable in terms of radiation exposure and that many of us have the CBCT available in the office, there is a rediscovery of the use of CBCT for the study of condylar position and blah, blah, blah. But the reality is that in the field of orthopedic medicine, the standard of care is magnetic resonance because you can see the soft tissues, you can see the presence of effusion, you can see the tendons. So that's something to consider. Also, by taking into account the possibility to use ultrasonography, echography as a screening tool. Okay. The current evidence strongly discourage, and that's probably one of the most important take-home messages of today, the use of electronic devices. I mean, chairside electromyograph recorders, postural platforms, kinesiography, okay, jaw trackers, because they are not accurate to discriminate between patients and non-patients, and because the ultimate goal of those instruments is basically to convince the patient that there is something wrong in the dental occlusion that should be repositioned in this or that way. Okay, so that's the real problem, not just the instrument by itself. TMD treatment should be, of course, directed to the reduction of pain and to the decrease of functional limitation, and also to the education of patients to manage re-exacerbations. And it should be primarily based on self-management and conservative approaches. Also in this field, it is very important to understand that the oral appliances are just temporary crutches. They are not the long-term solution. They should not be used in asymptomatic patients, and they are not something that is that must be used to define the ideal position for dental restorations. In some cases, even if rarely, as in all the orthopedic conditions, surgery is needed. Tumors, synovial chondromatosis, fractures, ankyloses, okay? Irreversible changes of dental occlusion are not recommended. And every time you get a patient with a complex clinical presentation, you should consider the possibility that it is not a temporomandibular disorder. Okay, so there are many other causes for orofacial pain, and it is important that you try to investigate for them in the differential diagnosis. So what I learned is that these are the faces of my patients. They are completely different from the everyday dental patients. And the simple fact of having an anxious personality, so a trait of anxiety, increases the risk of having TMJ pain of more than 3 points, okay? And if you put awake bruxism, that is something that my former resident, PhD student, Laura Nikanen talked about last week, if you put awake bruxism into the equation, the odds ratio for having pain in the musculoskeletal level skyrockets to more than 10, okay? So basically, the pathophysiological model is that the isometric pressure, isometric contractions, and constant and fixed pressure that is exerted on the fixed condylar and tendon surface determines an interarticular breakdown to the point that due to the mechanism of hypoxia and the lack of reperfusion, there is a free radical production that ultimately may lead to inflammation and to synovitis. So the model is pretty simple, okay? From the emotion, we got muscle tension, and as I said, there are the potential clinical consequences. So this is, according to the world leaders in the discipline of orofacial pain, this is the standard of care. And as students, you should feel the duty and also probably the privilege of being exposed to the standard of care since the beginning of your career. So if for any reason your professors didn't touch upon these topics enough, or even in some cases, they exposed you to opposite theories, it is probably for you time to get deeper into the argument by yourself to really take care of your patients. Most of our patients suffer from tendinopathy because the area of muscle palpation that are most always painful are the tendons insertion, masseter muscle, temporalis, and lateral pterygoid. And this is another paper that also involved my other son, Giacomo, is very instrumental to explain this kind of theory. So probably the real gate for you dentists to enter medicine and to embrace the correct discipline of temporomandibular disorders is bruxism. So bruxism, and here again you get a QR code for another editorial, is the topic that embraces everything because of the role as a risk factor for temporomandibular disorder. So basically, the early part of my career started with a jump from the moment in which the patient sat down in the chair to the treatment automatically. So there was basically no real anamnesis, no real diagnosis. It was a sort of one-size-fits-all technique and tactic. Let's get deeper into some clinical examples. Patients come to us because, for instance, of the click. Click may be due to something that is absolutely benign, because the patient tells you, I see a bone out of the face when I open the mouth. Look at that. Okay. This is what? This is just a subluxation. The condyle goes beyond the articular eminence due to hyperlaxity. It is absolutely not a problem, not a pathology, just a predisposition to some intra-articular weakness. In other cases, the patient may come to your observation and say, I have a click when I move my mandible. In that case, you can even hear the loud sound. That's the sign of a temporomandibular joint disc that is anteriorized to the condyle in the closed mouth position and is then recaptured when the patient opens the mouth. So basically the situation with an MRI is like that. In the closed mouth position, we have the disc that is anterior to the condyle, and in the open mouth position, the condyle translates downward and forward and recaptures the disc by sliding down below the intermediate zone. Okay, so in the moment of the recapture, also called the reduction, there is a click. And this is something that in the young ladies, I mean 20 to 25 years old, is not so rare just because of normal features of ligament laxity. Okay, so it is at worst a sign of intra-articular weakness. It is not a pathology. It is not something that should be treated as we did in the past by moving the mandible forward. Okay, it doesn't make any sense. In other cases, the patient may tell you, I feel a sort of obstacle when I move my jaw, and the trajectory is like that. This is the so-called intermittent locking. So there is a lock, there is a difficulty to open the mouth wide, but not always, from time to time. Okay, so this is one of the rare situations in which the disc really or may really represent an obstacle to the condylar movement and may be a candidate for surgical removal if the physiotherapy and manipulation and relaxation of the jaw muscles is not enough to increase the freedom of movement. In some other cases, the patient may tell you a story like, I had a click 20 or 30 years ago. Then the click disappeared, and now I got a sensation of having some sand, okay, beach sand in my ear or in front of my ear. That's a sign of attrition. So we could call it arthrosis. In most cases, it is absolutely asymptomatic, but it is almost all, I would say, not even almost, it is always accompanied by an anteriorized position of the disc without any recapture by the condyle during the movement. So those are, in the majority of cases, asymptomatic conditions. So they don't require treatment. It's like saying that my knee clicks and asking an orthopedician to treat it, okay? It's very unpredictable and unreasonable. Functional limitation is the main reason in most cases, together with pain, for patients to come to our observation. And functional limitation in the past, and also still nowadays in some classifications, we reported it as something that is associated with the malposition. Associated is due, more than associated with, due to the malposition of the disc, but actually it is a protective lock. There is pain, so there is a co-contraction of the agonist and antagonist muscles of the mandible that go into protective mode to prevent the joint from having further damage. So that's the basic rule of the pain adaptation model. And the lock, the so-called closed lock, some professor of yours may have used that term, is due to inflammation in the temporomandibular joint and the resulting muscle lock. The standard of care approach, you can see the patient after 1 week. The standard of care approach is moving the mandible laterally with this kind of gentle self exercises. Okay, so it's much easier than believed in the past. We will see that in some cases the resolution of closed lock is not so easy. And I mean, all those cases in which there is a huge amount of inflammation into the temporomandibular joint. Concerning pain, well, first of all, nowadays we have strategies to collect data on the habits of patients via phone, which is very important to teach them how to reduce their muscle load. This is a very basic case study. 34-year-old male with bilateral dual pain in the masseters, typical descriptor of muscle fatigue and tendinitis. And the patient was suggested by a previous dentist to move the mandible forward with that device, which makes absolutely no sense. And the app where the patient is asked to report the behavior every time he or she receives an alert, suggested us that the patient is basically never relaxed. Okay, so 19% of time green, it means that basically the patient is almost always bracing or clenching. The simple treatment requires awareness, gaining or the acquisition of awareness to move the mandible in a more relaxed way. And the more green means the less symptoms. That's pretty clear. What about the patient more specifically coming to our observation with pain? Well, first of all, if the patient doesn't have any pain, there is no patient. Okay, sorry for saying, but it's like saying that you should do the prevention by using appliances and stuff like that. It doesn't make any sense. So there is a very brief and easy to use instrument, the TMD pain screener, that may help you screening the patient for the presence of symptoms. If the score is 0, there's no patient. If the score is more than 0, you should try to get deeper into the reason and the location of pain. The joint load tests are very easy. You can ask the patient to bite on a bite stick, and if the patient reports pain contralaterally to the side of the bite, it means the pain is related with the joint. If the pain is ipsilateral, so on the same side, it is probably coming from the muscles and tension. Okay. This is especially valid when the patient tells you, hey, doctor, I got pain when I chew, when I close my mouth. Okay, so you have to discriminate between a potential TMJ inflammation or versus muscle or tendon originating condition. So when the patient reports that the pain is, especially when the mouth is closing, you can hypothesize a retrodiscal inflammation or a huge TMJ capsulitis. When the patient reports pain prevalently when he or she opens the mouth, it is very likely to have a synovitis in the anterior compartment of the joint. That is one of the main reasons, if not the main reason, to prevent a full translation of the condyle during mouth opening. So that's the main cause of limitation. And this is a video that Aurora prepared for me. The reference describing the arthrocentesis, perform the single needle technique with a single needle that I ideated together with Dr. Luca Guarda almost 20 years ago to wash the joint. We have a lot of courses on these techniques. To the lateral fold of the eye orbit. Normally, the entry point is about 1 centimeter in front of the tragus and a few millimeters below that. If you put the index finger in front of the tragus and ask the patient to open the mouth, moving the condyle downward and forward, you can easily identify the glenoid fossa that has been left empty by the condyle that has moved. In such a way, you can contouring your finger and drawing a line that is more or less identifying the perimeter of the glenoid fossa. The entry point is in the middle. Concerning the anesthesia, they are here anesthetizing the area of the lateral pterygoid muscle insertion into the capsule of the TMJ. The successive step is the performance of the external anesthesia in the preauricular area. My favorite option is always to use anesthetic without adrenaline to limit the possibility that this kind of anesthesia influences the facial nerve. Then the intervention, you should ask the patient to open the mouth. The direction of insertion of the needle is forward and upward. You should be able to touch the inner part of the glenoid fossa, so the medial wall of the glenoid fossa. This is the safest way to perform a safe procedure. Okay, in such a way you can be sure that if you get the needle a bit out from the original position, you are in. Then you can start positioning the saline solution. In many occasions, if you are properly into the joint capsule, you can notice that there is an immediate pumping effect. the needle moves, the mandible moves a bit, and you feel a sort of resistance, a sort of pressure when you try to push the fluid into the joint. Okay, look at the syringe that moves up and down, and the flow of the fluid out of the fossa when you ask the patient to move the mandible. The final step is the viscosupplementation. It is the positioning of the hyaluronic acid, normally medium or low molecular weight, into the glenoid fossa. The dose is 1 milliliter. And one of the advantages of the single needle technique is that you can position the hyaluronic acid without the risk that the medication gets out from the skin, from the hole of the second needle. So basically, this is a technique that, if it is managed properly, is very, very useful. I will say the standard of care to solve the closer lock when there is a huge inflammation of the temporomandibular joint. But importantly, if you know the anatomy, so on the left side here with the arrow, I am highlighting an effusion in the anterior compartment of the temporomandibular joint. In the other side, there is an effusion in the superior compartment of the joint. If you know the anatomy, it is pretty easy for you to understand that in these cases, there are different expectations with respect to the appliances, because if you use an appliance in this situation, so on the right side of the screen, your appliance will determine that thickness that is needed to keep the teeth separated and to prevent the cornea from getting high into the joint. So when there is retrodiscal inflammation, appliances are useful. But when a patient comes to your observation because of a limited function and you suspect the inflammation is due to a synovitis of the anterior compartment, the appliances are very unlikely to work since the initial phases of pain, because the risk is that they even push the condyle towards the inflammation. So the patient tells you the diagnosis, because from this very brief overview, it was pretty intuitive, I think, that if you know the details of the different symptoms, you can understand anatomically what happens, and then from then reach a treatment plan that is pretty useful for your patient. In some other cases, the patient doesn't even need to tell you the diagnosis, because when an individual comes to your observation with 22 appliances, like in this case, there is no need to say that you shouldn't perform the 23rd, okay? But again, this is one of the most abused sentences in our field. In medicine, probably, if you listen to the patient carefully enough, they will tell you the diagnosis. I always add, yes, but you have to know what to do with that information. When I was younger, the patients came to me, but actually came to my professor, saying exactly the same information that we have now. Hey, doctor, I got pain when I opened the mouth. But if you don't have a mindset oriented towards the anatomy that immediately makes you think about the possible inflammation of the anterior compartment of the joint, and blah, 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 that kind of information is absolutely useless, okay? And you risk to start unnecessary or wrong treatment. So according to these principles for our appliances, that's another issue that is very important for you to understand, because there are many misconceptions about the appliances. The appliances are just crutches, and we just I don't want to be interpreted as someone who says that they have a limited use or as a negative exception, okay? They do that. So it's up to you to understand when or when not they can be useful. So they must be rigid. They must have a symmetric distribution of contacts and don't have any forced position. Unfortunately, and I got very brilliant students who prepared collections for me every time we saw crazy appliances. The collection is now up to almost 80 appliances. These are some of the bizarre ones. We got the carjack, we got the flamingos. I don't think you are human beings and you are sensate and you are intelligent. I don't think that if your professor proposes you that you have to put these two flamingos into the patient's mouth for the temporomandibular joint, you should be so ignorant to take it as the standard of care. Okay, this is absolutely out of any reasonable subject. The mousetrap, the skateboard park, oral appliance. Okay, look at that, unbelievable. So the reality, and that's another editorial by my mentor, Chad Green, the real difficulty in those cases is to decide and to understand, admitted that it is possible, what to do and how to behave with the patient when you see the patient, when you see a patient having that kind of appliances. What's missing? Well, the so-called axis 2. I promise you to talk about the psychosocial evaluation. The easiest instrument for you to use is the graded chronic pain scale, 7 items that are not so aggressive, I mean, in violating the patient's privacy and intimacy. So with these very easy 7 questions, you can have an idea of what's going on in terms of the impact of pain for your patients. And I can tell you that if you end up with a so-called grade 3 or 4 out of the possible 5, that's about 15% of the patients. Those are the really complex individuals, okay? So all the others are pretty easy to manage. And for those cases, there is not a linear correlation with the clinical symptoms, joint versus muscle. So basically, you will be dentists, probably some of you are dentists, okay? Dentist is a sort of magic circle. As I told you, 100% of success in most cases, almost independently on what we do. Temporomandibular disorders is another sport, but in most cases, the nature of fluctuation of disease, the orthopedic nature of the symptoms really forgives you and gives you the possibility to take the good results home. But when chronic orofacial pain patients comes in town, it's another sport, okay? So it is the real problem where not only the access to, but the complexity of the central nervous system enters the arena. Of course, when I say that temporomandibular disorders are the easy part of orofacial pain and they are the nociceptive issues, don't take it too easy because, of course, not all pains coming from temporomandibular joint are acute and are due to local inflammation. I saw more than 15,000 real-life patients with pain in the face in my career. So in the number and also in the complexity of cases, because of my position, also some tragic situation happened just because of the number of cases. And for instance, amongst the many, many others, I remember this crazy case of silent lung cancer that provided metastasis to the right condyle, and the patient lost 6 months in 2 dental offices with 2 different oral appliances and painkillers, and ultimately she lost her life. Okay, so it is not a joke. To conclude, there will be always a lot of debate about gnatology, but it's like Santa Claus. When you're young or when you're a baby, when you're a kid, for the first 5 to 10 years of your life, or in this case, for the first 5 or 10 years after graduation, you believe in Santa Claus and you believe in gnatology. Then you realize, if you are a good sense person, that it has never existed, okay, because they are too complex dogmas for being really useful clinically. So thanks everybody, to my mentors, teachers, colleagues, because nobody can become successful by working alone. I invite you all, when you graduate, to consider enrolling in this world-leading master program for the postgraduate students. With this QR code, you could even pre-apply for next year, just in case that someone graduates in the next few weeks. So the international faculty is unbelievable, and you will have 2 years of possibility to learn online on a very frequent basis with top-notch faculty, all these details. And there are also complementary clinical activities on site. So to conclude, when everything comes to the clinics of temporomandibular disorders, the first thing to ask yourself is, who's your patient? Your patient has pain origins in the facial area, and pain is of musculoskeletal origins. So that's the definition, basically, of temporomandibular disorders. So what the patient says, if you listen to the patient carefully, should be the filter for your examination. And what you find should be the diagnostic target to be confirmed or confuted by the prescription of instruments. Prescription of instruments should be effective, so it may ultimately lead to confirm, or in any case, to have an impact on your treatment plan. And that's to steer the differential diagnostic process and address the treatment plan. So my career, that started as a sort of Danny the handyman with those screws and Facebook and everything, now, actually not from now, involves a lot of talking with my patients, my students. This is fatiguing. Thanks God, I got the mixed activity, clinical practice, also private versus public clinical practice, teachings, research, conferences. But the moment the patient comes out of your office without pain, is probably unmatchable in terms of rewarding. So what I can tell you as a final message is that I approached the world of gnatology and temporomandibular disorders because it was fascinating. It seemed complicated. But at the end of the day, I realized that we are talking about teeth. Okay, so there are some essential things. All the others are complicated and unnecessary stuff. And when you got professors who make you believe that you are not good enough to understand what they are saying, probably the only solution is to change profession and identify what is really essential for the practice of temporomandibular disorders and for helping your patient. because these will give you a lot of time to dedicate to what matters most. Thank you very much, guys.
Thank you. And I invite everyone to check on the postgraduate programs by the University of Siena, because they are really impressive. And I know about your program, your postgraduate program, and I know many international students are joining this program. So we have also included it in the postgraduate booklet for as an advice to everyone. And so I hope it works and it continues to for new experts in temporomandibular disorders. Now I have a question. If you have to design a simple for early practitioners, basically, practical screening and assessment protocol for TMD based on the overload model, which three elements would you include?
Well, that's a nice question. Not necessarily three elements, but the bottom line is pretty simple, Emiliana. You should ask your patient, you should search for similarities with other joints, okay? So let's assume I got pain in my knee. For being a real knee problem, that pain should increase when I move the knee, when I use the knee, okay? So the TMJ is not different. So what I recommend you is simply to ask your patient, do you have pain first? And second, does your pain increase when you move or use the mandible, when you chew, when you open, etc.? If the answer is no, there could be 1 million reasons for having pain in the face, okay? And that's not temporomandibular disorder.
So we have another question for one of the participants. Given the biopsychological nature of TMD and bruxism, do you think dental training should place more emphasis on this psychological and behavioral aspects?
Well, that's a tricky question, but the answer is easy. Absolutely yes. And I will say unfortunately, because I think this is a very common problem all around the world. Our profession, I mean, the everyday basis of our profession are technical, okay? In most cases, we don't even, sorry for saying, we don't even need to perform a diagnosis, no? You have a patient with tooth pain, you simply get the anesthesia, use the drill, root canal treatment, and that's it. That's a technical procedure. It has nothing to do with medicine, okay? So medicine and pain, by definition, is a subjective experience that requires a psychological and social, not only a biological evaluation. So yes, emphasis will be needed. We are chewing on the best possibilities, but the reality is that most of the programs that are around the world at the undergraduate level cannot be changed so easily. So it's up to you to get deeper into these topics after the graduation. And currently, if I can tell you the truth, my recommendations are to follow the key points that we published in Cranio on behalf of the IDR. For sure, our master program is the #1 in the world right now. There is the International Association for Orofacial Pain that is absolutely to recommend because it is low cost, zero cost in most cases. And then the top continental association is the American Academy of Orofacial Pain because it really embraces all the causes of pain with many clinical information. They got a textbook, guidelines, a lot of activities, many members, much more than in Europe and in other countries.
Okay. So, Haya, one last question, and we are basically discussing a real paradigm shift. If you have to summarize it in one sentence, what makes the overload model fundamentally different from the traditional occlusal approach?
Well,
Real difficult one, I know.
No, it is not difficult. It's like saying, how can I say, what is the difference in saying that you're anxious with respect to the difference that you are obese? Okay, it doesn't make any sense. Okay, in reality, probably it is not so diffuse right now, but at my time, there was an automatic way of thinking. You got
Okay.
anybody with pain in the face, the reason was malocclusion. And the symptoms, in most cases, disappear by themselves. So basically, independently on the type of appliances, the crazy designs, orthodontics, the electrodes, 80% of the patients tend to improve. And this fostered a business. Books have been written on the choice of temporomandibular disorders as a business disease, okay? As a disease that is ideal for business. So the main difference is that the occlusal paradigm, which was actually scientifically speaking abandoned 30 years ago, maybe even 40, the occlusal paradigm was based on the mechanical origin of pain. And by the way, a mechanical origin originated by something that we don't use. Because if I ask you, how much time do you use your teeth during the day in maximum intercuspidation? The correct answer is probably never. Because even when you bite and you chew, you got the food interposed between the two arches. Okay, so that model is completely faulty, and the only reason for that model to stay alive is the money and the easiness of treating patients. Okay, and the frailty of the psychological profile of many patients who get involved in this kind of symptoms. On the contrary, the psychosocial model is in line with everything. Individuals who are hypervigilant, who have an anxious personality, who have a need to download the neural charge are more likely to be predisposed to musculoskeletal consequences because they brace and clench, and also to neurological consequences. We see a lot of patients with burning sensation in the mouth, post-endodontic pains, even if you got perfect root canal treatment. Okay, so the biopsychosocial model doesn't mean that everything is in the patient's mind. Okay, it simply means that the jaw muscles are used to discharge the emotional load. And if you use those muscles too much and you are, for many reasons, a predisposed persons, like in the gym, you may have consequences. Okay?
So basically, what have to change is the mindset of the practitioners.
Yeah, I always say, my friend, my next generation, that even if I cure my patients by prescribing an app that is basically free, I got a luxury car, I got the swimming pool, I travel business class. Sorry for saying, stop the recording now. But so all this kind of making everything in the shape of business is ridiculous. It's ridiculous. You have to do what. Yesterday I was giving a course in Naples, okay, and a doctor approached me saying, "So if we prescribe the app and the patient has an insurance, what should we charge?" And I had to ask her to repeat the question because my feeling was, are you serious? So you have to charge something at any cost? If I go to the neurologist because I got headache, I pay the visit, he gives me some drugs, and he visits me again 3 months from now. Why are we dentists not able to do the same with our patients, okay? So that's the mindset, as you said. Doctors versus lab technicians working in the patient's mouth. You are doctors.
Thank you so much for this overview and for having this chat with me and for your expertise and for this lecture, and it was really insightful. We sincerely appreciated the time you dedicated to us today and the valuable knowledge you shared. And I really appreciated this lecture and this presentation. And before we conclude, I would like to remind everyone to please scan the QR code I'm showing for the attendance. And thank you so much to Professor Manfredini for this lecture and for accepting our invitation. And thank you.
My pleasure. Ciao.
Ciao.